So maybe we are ready to start. So as mentioned, this webinar will be recorded. So welcome everybody to the FCAI HiDATA webinar on AI and data science against COVID-19. And I'm Patrick Florén. I am the Vice Director of HiIT and also the Vice Director of Helsinki Centre for Data Science, and I work also in the Finnish Center for Artificial Intelligence as Manager for National Collaboration and External Relations. And we have today two interesting talks. And actually, we will first go to Mika Leminen. Mika Leminen has a background in both engineering and psychology, and he has previously been working over a decade as a brain research laboratory engineer at University of Helsinki. And currently he works as a development manager in HUS IT department and leads the unit called AI and Analytics Development Services. So HUS is the Helsinki University Hospital. So we give the floor now to Mika, and then after Mika's presentation, we will have a second presentation by Professor Pam Hui, who has also joined us. So we start now first with Mika. And here is he both in picture, and I hope you can see him also in the video. So we are ready to roll. The floor is yours, Mika.
Thank you. And as you may see, my beard is getting bigger and bigger. I hope I get out from the home at some point, so I get my hair done. Okay. Do you see my slides?
Yes, I do at least.
Very good, very good.
See them.
So I will stop my video so you will get a little bit more bandwidth. So very much thank you for this opportunity, and I won't be showing you any equations or I won't be going into model insight too much, but I thought that it might be really interesting to you, at least some of you, to see and hear a little bit about what happens behind the scenes and when we have been working quite heavily for the last 3 months in the HUS University Hospital. But first, a little bit about agenda. So first I will just shortly tell who we are and what we do when there is no pandemic around, and then I will go to insight about what we have been working with. I guess that during the situation, I mean, it's been really interesting to see how data has been there in public media almost daily, and I guess everyone knows more or less about everything that happens there with the data during the pandemic. So in that sense, it's been really educative, at least for the basic public who won't work normally with the data. But I will just discuss shortly about some important points that we have met and what most likely also will help you in when you review all the media articles, but also the research papers that there will be coming out from the COVID-19 cases. I will shortly set light about some legal issues and collaboration work we have been working there. What is it to work with healthcare data in real time, and what kind of rules and laws you should follow. And then finally, a little bit some words about the scenario models we have been working with and what has been used for managing the HUS University Hospital actions during the pandemic. And of course, the same method will be running for quite a long time from this, because situation is still in really active phase. But that's about it. And about AI and analytics development unit in HUS IT department, we are basically managing the HUS data lake, that is the storage for really randomly shaped data. So basically, we are acting as a data hub. We try to collect all the possible data we can get, and basically, if there are some needs where the data needs to be used, then we are taking it from data lake. So that makes the organization level architecture simpler when you don't have to make point-to-point integrations between every possible system there is, but there is one data hub where all the data is collected and where the data is used from. And our data scientists are then basically mastering that data. And that's why our data service then, it's by the way defined by the law that the healthcare data should be given for secondary use if there are some permits for that. And that is the data service that we work. So for example, if you apply the data permit from FinData, for example, then it will be our data analysts and data scientists and other data professionals who will be then working with the data, even if you get it from somewhere else. But if it's HUS registry data, then it's us. Then we also do like AI machine learning application development, and those applications that we got into running, and if they need like CE marking for the medical equipment, that is also something we do, and then we take care of them during the production as well. So we have both IT professionals and data professionals. We also do some custom analytics, especially when there are some development needs for the HUS operations, and also during this pandemic situation. That's more or less what we have been working with. And then quite funnily, our unit also is responsible for all the IT services for the research and teaching in HUS University Hospital. So basically kind of more normal IT stuff. And if you are familiar with the tutkijan työpöytä, that's been in our responsibility from the beginning of this year as well. And I will promise you that there is currently going some improvements, heavy improvements for that system. These organizations didn't ask me to thank them, but I just want to publicly thank them, because I also want to give you some seed that it's really important that some commercial, and why not also academic professionals give their valuable work for free for society. And also in this situation, quite when pandemic was still starting in March, we got lots of messages from different organizations, and quite heavily we have been working with these two organizations. So they have been offering some data scientists for us, and also some data insight and consultants and etc. So I just want to remind you that maybe you could in also some similar situations in future also try to think if you could really maybe we don't think in Finland that you could offer your work for free for public, then that it's something like that people in US do maybe a little bit more, for example. But this is definitely something that has been really big help for us. What kind of data we have been using? Well, that you know most likely, more or less. But I will shed light a little bit into most important difficulties that we have had, and you have maybe not noticed from the public media. So, for example, diagnosis. When the new pandemic starts, it's quite fast-moving target in the beginning. When, for example, diagnosis codes were not internationally like published, and when they were, it took a little bit time when they made the national guidance for those, and then it took even a little bit more time after that when it was available in all the different medical healthcare systems. So basically, especially in the beginning, it was quite difficult to track all the patients where some different hospitals and organizations and units were using a little bit different strategies, what kind of diagnosis to use. But of course, after a few weeks after the beginning, then it got a lot better when everyone was using like same codes and of course correcting the data in history, and everything got kind of in production quality level. Laboratory results is of course like main data source. That is something we routinely get to our data lake every 15 minutes, so it's quite real time. But like you know, and you have seen from the public media, that they used to say that for the few days after, for the last few days, the data is not too reliable, and especially in the beginning, of course, like it took a little bit longer time to get those results out from the labs and to the systems, and that's why it's quite challenging when you try to real time track something and you kind of don't know that that is this value from or number from yesterday, is it already reliable enough, or is the population big enough already, or how much results there will still be coming. And this of course improved a lot also when the delays got shorter and shorter, and of course we used to manage that source of error as well. Bed count, it sounds funny, but it's also quite challenging. First of all, intensive care, CU is for intensive care units. So basically, of course, this is the most important, like how many patients you have, and for the COVID-19 disease, and how many of them are in intensive care. But it's not so simple question, because there are several levels for intensive care. That what is heavy intensive care enough to define it as intensive care, and this is also makes it a little bit challenging to compare numbers from different countries when the criteria can be slightly different. But of course, for us, it meant that our like clinical managers then make the definition that okay, these are the bed size that we define as intensive care in our public or official numbers, and these are not. Also, that it's quite complex filtering criteria that tracks those patients, that okay, you need a positive lab result, but of course you know that lab results are not 100% correct, and of course tests are done many times for the same patients, so it's already quite complex logic behind there that defines that if this is really confirmed case now or not. We are been building quite quickly different kind of weak signal measures, and those are quite important, especially now when we are like try to be sensitive for the beginnings of the next waves if they come. And then, for example, contact activity in päivystysapu that you should call before you get to the emergency department, and other early medical support channels, chatbot activity. We have been building several chatbots during this pandemic, and activity in all of those we track actively. Population mobility, we get the we can use like but aggregated data from ELISA that we can, for example, when it was really heavy times, when we didn't know what happens with the pandemic, and it was still like patient numbers were increasing every day, like exponentially. We were also able to see that if some post number area, the numbers were really high, we saw like activity and mobility like profile for those areas. And also, of course, we were analyzing quite intensively data from other countries, and also during this situation was quite different from all the previous ones, that we really got data from public sources in Finland, but also worldwide. So it was quite easy to analyze carefully, for example, Denmark numbers after they opened their schools and stuff like that. And then we made, this is like example picture, doesn't show real data or real layout, but we made kind of different kind of screens, dashboards for that the HUS managers were using and when they were making their decisions. So we have there, it's running still all the time, real time, showing different important numbers and measures about logistics, patients, personnel, pandemic situations, lab results, and of course these scenario forecasts. We started quite intensive collaboration, especially with city of Helsinki and other HUS area cities. But then I just want to remind you that it's quite different from research, that because then every data that you would like to share, you have to really carefully define that what is it, where is it coming from, who owns that, under what law we can enable using that, and what organizations we can share it with, and with what accuracy, and that's why it's quite heavy work that we daily basis we try to we have to solve some issues, and of course we need to do everything right all the time, because it's also your data there. We are really careful, but sometimes it feels like that it's slowing us down, but of course we have to do everything right. The scenario models, basically we have been using like basic SAIR model, so exactly the same that most of the people worldwide are using. Then the difference is just there, that how you exactly define your parameters, and it's seeding Markov chain model that then tries to tell that, okay, this is the population level infection statistics, that how many of them will turn to intensive care or some other places. And then of course we were adapting this to the real case all the time. We were estimating our parameters all the time when we got better and better information. Of course, in the beginning of the pandemic, when people just got into department but didn't get yet out, we couldn't like estimate carefully that what is the length of stay and so on. But of course, and in public media, the discussion is focused on R and RO, but of course there are many other parameters that are also really important. A couple of examples.
Mika, 3
yes.
minutes. 3 minutes.
Thank you. Thank you. So examples from our public press releases. So 13th of April, you can see these in the HUS website, that we were showing that we had the like public governmental like model estimates there as a background, and then showing real-time data that okay, we are really following this line, and of course the situation looked really bad because if we well, situations looked really bad at that time, and then right side you see our models from the median model as yellow, and then the 95% worst case media results at the right side, and left side the median scenario model. And 10 days later, the situation looked luckily very different. That you showed, you see the same background model, but because of those limitations for the society, we turned that number down, and then of course scenario was adapting, and scenario was quite accurate all the time, and of course that was updated every, maybe not daily, but every second day, a couple of times a week, and it's been quite accurate. The median scenario model was quite accurate all the time. And what we have learned now, or tips that I want to give for you now, like get going. I mean, it's always difficult when you can't know your parameters, but you have to start from somewhere, and then you can't just stay and wait for the perfect data, and then make it better when the data gets better. But also try to take it into account that when you know that what kind of data problems you might have there, that your modeling work should be robust against it. Use parallel strategies where several different models give different results, but if you really understand why they give different results, then you are already like one step ahead. And in practice, in our case, we didn't try to model like the long-term population where the overall long-term peak will be, because that is not that's something we have lots of error in, and also it doesn't. Now we have to decide that how many intensive care unit bedsides we need to have next week and 2 weeks, and for that we need the short-term modeling, and there may be some other modeling strategies work better than those population level statistics. Lessons learned and how we are ready for the next waves. Well, of course, we have built these data pipelines and quality control. The reporting has moved from monthly reporting to real time, and we have been building these weak signal measures that we monitor all the time. We have been building these collaboration networks with different organizations, but also building connections between, for example, data connection between City of Helsinki data lake and our data lake, so we can quickly share data between them, and having these different modeling strategies live and running, and also choosing where to use your resources. Like it would be interesting to do different kind of AI, like neural network models for lung X-rays, but that was not our like acute need. Our acute need was to predict that how many intensive care bedsides we need next week, and then you have to focus there. And thank you.
Okay, thanks, Mika. So now we welcome questions from the audience. So please ask for the floor by raising the hand in Zoom. The blue hand you find under the participants. And another alternative is to send a message in the chat. I see no questions, so I ask one myself from Mika about the data lake, just to clarify if I understand correctly, that in the data lake you have only the HUS data, is it so? Or do you also have, you said that you had the link to the city of Helsinki data, but does it mean that you don't copy it, you have it, they have it there, so you don't have data from the occupational healthcare, you don't have from other hospitals, like other university hospitals, you only have the HUS data. Is that correct?
In normal life, that is correct. And of course, though has to be kept like logically separated. But of course, during the pandemic, we also got right to get some private sector data, laboratories, also occupational health data, but those are, we are not mixing that with the HUS patient registry, because it's always some other data than HUS patient registry data is, it has to be based for to some other rule or law or request. That, for example, during that kind of pandemic situation, when the head infection physicist requests some data from anywhere, then that is really strong request, and then we have right to get it. But basically, we are not mixing that to HUS patient registry, but you're using for pandemic only. And when the situation gets over, then we have to delete everything.
I don't know if you know the answer to this question, but we referred to this already, that one person is tested many times often. So when in the public there is published how many tests have been taken, it actually doesn't tell how many people have been tested, because it's a completely different story. So do you have some numbers? I think you have seen them, but probably haven't looked it up for this webinar. But what is the ratio? So if you see a number of 10,000 tests, does it mean that it's 5,000 people that have been tested, or what does it mean in reality? What's the share?
Really good question. And other question is also about bedsides, that the same patients sometimes come again, and quite often they have a couple of short periods in the intensive care unit, for example, get out and then get back, and then of course it's trouble. That do you count it as 2 or as 1? And of course, for those numbers we have for inner use, but then national THL then defines that what kind of numbers we report for them. But yes, for own report? Management. Sorry.
So what do you report? Do you report just the crude number of tests without taking into account if it's the same person, or
number of in this case number of positive lab results, for example? Okay. That's as a daily count, and of course then usually it's just one person once. But for own use, we of course have follow both separately, that who are new patients with the positive results and etc.
And there is one question in the chat. Can you read it yourself there? Or so Marina says that how did you really get the permissions to get the data from outside of HUS? That is there a specific legislation for in the pandemic situation, or what was the legal basis for this?
Yeah, that is correct. That the alertness level of the society also gives this infection physicist really great rights to get about anything they need and want to handle the situation. And so that's why you have to make the official request. But anyway, that's a lot easier now in the pandemic situation than normally. But normally you could of course apply some secondary data use permit, but it's a lot slower process.
Okay, I hope Marina is satisfied with this. I have one more question. I don't know if you can, thanks, yes, if you can answer this or not. It might be confidential, but it was interesting about the support from Elisa and Boston Consulting Group. Is it possible to open up a little bit what kind of service they provided for you? What was the type of collaboration you had with them?
Yeah, I guess some of them, at least Elisa has also making own press releases about their work, and they have been helping in different things. For example, with those in our unit, they have been helping with this like weak signal and data dashboard processes for the real-time reporting. That was something that we didn't really have before, and they had really good experience on that. Also, they were sharing with us this mobility data.
Oh yes.
Anonymous mobility data, and also some data scientists were working with that. And Boston Consulting Group was mainly focusing on many different things, but especially with the scenario modeling.
Okay.
Because they were working with a similar case with worldwide in over 100 different organizations, tens of different countries. So they basically had really good insight, and we could use that information.
Okay. So thanks to you, Mika. We go forward in the program. Time is running. So now we turn to Pan Hui. Are you there?
Yes, I'm here.
Yeah, you can put the video on. So Pan Hui is a Nokia chair, is the Nokia chair in data science at the University of Helsinki, and he's also director of the Systems and Media Lab at the Hong Kong University of Science and Technology. His research interest widely covers data science, ubiquitous computing, mobile computing, and augmented reality. He's an IEEE Fellow, an ACM Distinguished Scientist, and a member of the Academia Europaea. He has published over 300 publications and has an H index of 50. So we are very happy to have Ben here with us, and I think I give immediately the floor to Ben, and as before, you can put your questions in the chat, and then we have a short questions and answers session after the talk. So please, Ben, the floor is yours.
Okay, thanks, Patrick, for the introduction. So I'm going to share my slide now. Okay. Okay, so thank you. So I'm in Hong Kong this couple of months, so it's a little bit late for me now for dinner time. It's okay. So yeah, it's good to talk to you about this, about some of our research in this area. So as I mentioned, I have been in Hong Kong the last couple of months. So actually, I can report a little bit about the situation in Hong Kong as well. So basically, the first case in Hong Kong actually started on the 23rd of January 2020. So it's like over 4 months ago. And then so far there's 1,107 confirmed cases. And most of them actually are imported cases. For example, 671 cases are imported from somewhere like Europe, US. And the local confirmed cases was just like 68. So they're like less than 7%. And there are some of them actually, they are suspected local cases. We are not sure whether they're local or from somewhere else. And also there are some other cases, around 200 cases was just some close contact with this confirmed case. So in total, only 4 death cases so far. Consider about the Hong Kong is like just neighbor with the mainland China, right? So it's, the death case is pretty low, and the reason why there's not so many cases, and especially the death cases, you can look on the figures over there. That this is the picture from January 30. So basically, just very at the very beginning of the coronavirus outbreak. And people, the picture showing the people are queuing to buy masks at the time, right? So at the time was no mask anywhere because it was the Chinese New Year. So all the factory in China closed down, and people got masks, and you cannot just get masks over there. So this is just a picture showing 500,000 of people queuing to try to buy masks from a shop. And at that time, you know, everybody, so the strategy that for Hong Kong is that, you know, have the universal masking strategy that everybody have been wearing masks, you know. Of course, at the beginning it was very difficult to get, but then, you know, you get masks. So almost 99% of the population was wearing masks all the time. So this is just on the street, you know, just a snapshot of the street. And this also in the metro station, right? So you can see that you don't see anyone who is not wearing mask. So probably this is the one of this reason that, you know, the case was controlling so low over there. So I have been a couple of projects in this area, you know, since January. Even the number of cases was very low at the time. I thought, you know, it's going to be quite serious because we have experienced this SARS in 2003, right, at the time, and you know, even the case was, you know, low, but, you know, people were already, you know, concerned about that in Hong Kong, that, you know, it's going to be very big. You know, people was worried. So I was also kind of, you know, consider about this. So we haven't started collecting data actually since mid-January. That some of the data that we have been starting collecting data from Twitter, from, you know, some of this Sina Weibo was, you know, like a Twitter type of thing in China since, you know, at the beginning, like mid-January. So and we're also trying to, you know, besides the social media data, we're also trying to, you know, follow up this data from WHO, and then also there's some data that we have, you know, from University of Helsinki, have this color project, which is, you know, a platform that people install app, and this app is basically is not collecting personal information, but more collecting about the information about the app usage on your phone. Okay, so we have, you know, using data science to study multiple aspects, not directly as the previous speaker, Mika, they have really doing the, you know, directly on the patient, but we are, since I'm not really a medical worker, so we are more looking at, you know, from a data science point of view, or, you know, on the data that we can collect. So there are 3 projects going on in our lab, and one is the modeling global public health strategy in the COVID-19 pandemic using deep reinforcement learning. So this project is using the data set from the WHO. They provided the data set since 21st of January, and for our project we take a couple months until April for learning. And the second project is on these, as I mentioned, the color data set that we have a global smartphone usage. And from this data set, we're trying to understand about the impact of COVID-19 on smartphone usage, how the people using smartphone be actually influenced or, you know, affected by the pandemic. And the third one is mainly, I will cover a little bit more on the last part, is about the semantic analysis on the social media during the COVID-19 period. So this one we are going to use Twitter, although we also have the data from mainland China as well, Sina Weibo, which is, you know, Chinese language. So for the global, but I will briefly talk about these, the first 2 projects, just 1 or 2 minutes. So for the global public health strategy, we use the WHO data, and we're trying to, you know, training up some kind of reinforcement learning, and to come up with some strategy with, you know, controlling, you know, different kind of, you know, policy that the government may implement. So for example, in our study, we have signed a 3x3 action space. So basically, you know, all the action space that the government have been taken these days. So the strategy include, you know, lockdown and then travel restriction, right? That for the lockdown, there's 3 strategy that government can take. Like, no, for example, the first one is no actions or restricted social gathering, and nationwide lockdown, right? For travel restriction, we can have, you know, you have the 3 strategy as well. So no actions, flight suspension, that, you know, you stop the flights, and the last one is closure of the borders. So these are the action space. You're familiar with the reinforcement, and you know that, you know, you have this action space to select the actions, and then you also have the reward, right? So the reward is that we punish the strategy that which we accelerate increases in the infected case and death, but we encourage or, you know, basically the reward, right? For rapid acceleration of the recover case. So these are the reinforcement strategies. So based on the data set, actually we found that there's a lot of interesting discovery, but still ongoing. And what is the find out we found is from that, that the data that most of the countries actually are a little bit too late for implement this kind of lockdown strategy. They could so the delay is like 1.5 months. So if things can be start lockdown or restriction 1.5 months earlier, then the situation will be much better, compared to the current situation. And then there's also the impact on the smartphone usage found is that, we try to look at the people's, from the data set, how people's using their smartphone, right? So then you can see that so there's some figures over here. So you can see that the top ones are about the memory usage and the bottom ones about the Wi-Fi usage and also about the network switches. So basically the memory usage tell you that how much memory that you are using your phone, right? If you are intensively using a lot of application on your phone, then it's going to, the memory usage will be higher. And you can see that that the memory usage basically is you follow the trend, but it's inversely follow the trend of these the number of cumulative cases and new confirmed case. So basically, it kind of implies that basically that you're using less and less memory when there's more, the situation getting more serious of your smartphone. And the same case is also actually that about the Wi-Fi case, that you likely to use more Wi-Fi rather than stereo network when the situation is getting worse. And the network switch case, it means that actually, you're switching from these smart, different kind of cellular tower or switching from cellular to the Wi-Fi, right? So it's more, network switch means that you have a higher mobility pattern, right? That you have higher mobility, you're moving more, means that you have a higher percentage of network switches. And you can see that if you look at the y-axis, right, that for the network switches, you can see that we arrange inversely. So in the top is lower, and in the bottom is higher. So basically, it means that when there's more cases happen, that actually your mobility is limited. And the memory case, that basically it tell you that okay, when the case is getting serious, you stay at home using more Wi-Fi than using cellular network, right? Because you are indoor. And the memory case as well, that you are not using so much your smartphone for application. Maybe you are using since that you are stay at home, you are more using other entertainment, for example, your laptop or your computers or watching Netflix. So those are the things that we observe from the data. Okay. So let me quickly go through these, spend more time on these social media cases. So as I mentioned, those are kind of ongoing work still, but I have some result to show. So I mentioned that we have collected this a lot of data from the Twitter. And the motivation for these studies, that have three motivations here. The first is that the social media platform provide an easy access to discourse of large population, right? That they can provide us with some valuable insight about users' opinions during a pandemic, right? Whether what are your sentiments, or what is your psychological feelings that they can go or a psychological health, which is not only about your physical health, but maybe also about your psychology status, right? And the second one is we want to understand how people use social media during the crisis, and so in order to do this, we need an efficient way of looking at the data. Apart from the social media, we're also trying to solve the role of using social media using a survey, right? So we trying to, so we collect data from social media, but we also want the feedback from the users, whether what is what are the role of the social media in their daily life during the pandemic periods. So apart from the collecting the data, we also run some experiments, basically not experiment, but more questionnaire on the Amazon mechanical Turk surveys. So we have recruited 200 participants from US. So why we're looking at US? Because we found that from the data set that from Twitter, right, that there's a lot of tweets are from US based, and because we just look at the English case, right, and there's a lot of tweets are from US. So from the US case, so in order to just focus on the study in US, we just filter out the tweets which are in US. So in order to kind of matching the tweet data, we also do the survey just based on the US citizens over there. So from this Amazon Mechanical survey, you can see that we have this show you the demographic of this participant, right? So you can see that the more of this age is from 25 to 34, but there's some people also about 65. And the education degree, so and most of them have at least 4 years of degree, so which are the people are quite highly educated, and there's some people which also have PhD over there. And those are the information that we asked them. So basically, they answered that they have sorry, actually I forgot to switch off my. Okay, so basically, so basically what they say is, you can see from here is that okay, so yeah, so most of them actually using what kind of information they are looking for, right? So 44.5% of the time that they would like to get the COVID-19 daily case statistic, and 45% of them actually also paying attention to the news report about COVID-19, and 10% of them actually they're interested in engaging in more COVID-19 related discussions over there. And many of them, you see that from the left-hand side figure on the bottom, that the social media is among the most used media for information seeking. So you can see that many of these participants actually get information about COVID-19 by using the social media. And also a large portion of them actually also use social media to share the information about COVID-19. And then there's when we ask them about the questions, that you can see that they have COVID-19 is used for some interesting things. They use it for some political discussion. So although it's about COVID-19, but many of the discussions that the users have used is about politics. So you can see that strongly agreed, around 20% of them strongly agreed that the COVID-19 is used for political discussions, and 35% of them agree, and only very small number of people which disagree. So so it's kind of political ties as well. And then many of them actually also agree that the COVID-19 can make people with a different opinion engage with each other, right? Even they disagree with each other, but they it getting a topic for people to discuss. And we also look at the emotional, or basically the same sentiments of the people on the tweets, right? So you can see that we are using the tweets. We use emotion. So basically you divide some kind of 8 primary emotions over here. For example, angry, anticipation, joy, trust, fear, surprise, sadness, and disgust. So these are the 8 primary emotions. And then the combination of 2 emotions can lead to a new emotion. For example, anticipation and joy together will become optimism. Will be generate optimism. And for example, joy and trust together will generate love, right? So those are these 8 primary emotions, and the other emotion that we generated by them. So from this data, right, that this table actually show you the 8 emotion and the behavior effect related to this emotion. For example, fear, it will lead to you withdraw from the stand and inspire the protective behavior, right? That when you get angry, that you will lead to some kind of destructive behavior that we all know, right? So then disgust will lead to the riddance and rejection to the opposite opinion. So these are the behavior effect that can associate with this emotion. So these are Twitter data set that we analyze. So there's over 70 millions of users and 88 million tweets. So after process some of the tweet, we filter out 37 million tweets. And so these also show you the number of tweets per users. So some of them are quite heavy, some of them are kind of, not too many tweets over there. So this is show you the based on the NRC lexicon. So it's kind of cumulative percentage of emotion over here. So you're looking at the tweet, right? So you get this. I mentioned this 37 million of tweet related to COVID. So those are the tweets are all COVID related. So there we have some hashtag about either coronavirus, COVID, Wuhan virus. So you can see actually the tag also evolved with the time as well. That with different time they have using different hashtag. And you can see that
2 minutes, Ben.
Okay, 2 minutes, fine. I said it the right time for me. So then you can see that there's the major emotion over there is like trust. So for trust, you have 89%, and this emotion on the tweets kind of keep quite constantly from February to May. Kind of the level is kind of constantly, and the most the highly ranked emotion are trust, 89%, disgust, 89%, and then also have anticipation, right? So you may kind of feel strange why trust and disgust are the highest rank, right? So basically, if you look at this table and you can, they're the top highest ranked emotion over there, right? So anticipation, you can see that the topic usually talking about school opening, so people expecting the school opening, expecting, for example, those things, right? That people anticipate something. For the disgust and the trust, usually they're related to the political issues. For example, the discuss about Trump, about president, about coronavirus, and some of them, are angry for employment, and some angry about China's, and something Wuhan. So those are kind of disgusting. And that's trusting, right? The trusting also, some people, you can see the US are kind of very bipolar, right? Some people trust Trump, some people distrust Trump, so there's some people like the presidents, people hate them. So there's kind of, the emotion kind of associated with them, but, it just reflects this political stand in their society over here. So there's also some vocabulary about crisis that they were trying to also understand what kind of vocabulary that people have been used in this during the crisis. So we have kind of, you use some kind of vocabulary rank algorithm that, they try to rank the different vocabulary with the ranking. So there's some algorithm they use that there was algorithm from the DAP conference in 2019, which are using some method to monitor these social media's geospatial pattern and interest. So we have kind of improved the algorithm by including some kind of entropy, taking entropy into this account. So you saw some of this vocabulary that this is original method in the DAP 19 paper. So you saw that it give you some word, right? So some vocabulary that people use quite often is COVID-19 over there, just a little bit sparing, and then there's but it also give you some kind of some other different kind of words which does not mean so much, like use, doctor means something. But then for our method, we kind of instead of bias to some kind of super users, we have some kind of kind of more taking care of some other more useful keywords, right? So for example, stay home and New York Post are kind of highly ranked, but some kind of those terms are with our method they are lowly ranked. So kind of so more details.
Then you have to finish up. We're out of time.
So I finish it up.
Great.
So thank you for your attention, and I can take some questions if you have.
Thank you very much.
Thank you.
So let's go to questions. Are there any questions from the audience? Raise your hand or put it in the chat, please. If not, I wondered about the WHO data that you have. So so what are you going to do with it? So is it going to produce a kind of tool that the governments can use for what kinds of restrictions they should take?
Yeah, so this is actually the WHO data, right? That everybody have access to. You have show you the cases every day, the new case, new recovery, number of death, right? So so you can put in this into the reinforcement learning model, right? And then the reinforcement learning with this action that we'll be able to encourage actually what kind of strategy to take with the number of new cases and the recovery case.
Yeah.
So it's kind of tool, definitely.
Then about the current data, your second data set you had, so that's a global data. And you showed the results which where there were like real clear effects of the COVID lockdowns in the Wi-Fi and other use. So was there national differences, or have you looked at these kinds of things, or did you just look at the whole data set?
Oh yeah, thank you. Yeah, very good question. Yeah, the current data set is global, but unfortunately that there are not too many international use. You know, there are many users at each country, but each country there's not so many users. So the data I'm showing here are the US users. So there's a few hundred US users over there. So you know it's more kind of US specific for the figures that I'm showing there.
Okay, sorry, I missed that it was US. Okay, yes. You said for the Twitter that you were using two data sets actually. You had the US in Twitter, and then you actually had the Sina Weibo. So have you been looking at is there a big difference here in China respective to US?
Yeah, we haven't actually looked at the Sina Weibo because we got so much data. So,
okay, I understand. Okay, and we are running out of time. So
yeah, and then we could not have the machine enough, right? So we process multiple data, so we could not do it on time. You know.
I see. Okay, so this is ongoing work.
But it's very interesting to see, as you say, maybe very interesting to see the difference, right? That people have very different emotions. You know. Yeah.
Okay, thanks. So thank you for this. Now we are running out of time. So thank you all for participating today. And we actually have one more coming up. So I think you all know that in Finland we are pretty much closed down after midsummer because the people take their holidays, but we still have time for one session next Monday, the 15th of June at 2 p.m. We have the next session. So welcome to join us again next week. Thank you, everybody. Thanks to the speakers and thanks to the audience. See you. Bye-bye.
Thank you. Bye-bye.